Okay. Hello everyone. Catching around after lunch. I'm sure the sleep monsters are starting to hit. So today I just really want to thank IHH Parkway for organizing this talk and this opportunity to share with you a little bit about prostate cancer. So I'll start off with this image. This is prostate cancer incidence in Singapore in the last 30 years. So as you can see, in the last 30 years, the incidence of cancer has gone up about 11-fold. And what we find is that currently prostate cancer is the most common cancer in males. So obviously we want to try and pick up early because of this. If you are picked up with a localized prostate cancer, your overall survival for 5-10 years is excellent, between 97-99%. Essentially, if you are picked up a localized prostate cancer, you are not going to die from it, not anytime soon. On the other hand, if you look at the other picture, metastatic prostate cancer, it is not so good. The 5-year survival with metastatic cancer, that means when the cancer has spread, is down to 37%, and at 10 years, even worse at 18%. And this is 2025 data after we've had new drugs introduced for prostate cancer. So the key takeaway from this slide is really, if you pick it up, is a rising incidence. If you pick it up early in the early stages when it's localized, excellent survival. When it's metastatic, that means it's spread beyond the prostate, then survival is very, very different. So how does prostate cancer screening affect survival? If you are picked up in an early stage, which is localized on the left, it's 80%. If you do screening, you have an 80% chance of picking up cancer in the early stages, that means localized. If you don't do regular screening for prostate cancer, then there is a 36% chance that you're picked up only when it's localized, or importantly, a 64% chance that you're picked up after it has spread. So obviously, we want you to try and consider doing PSA screening as a test. So when do you do all this prostate cancer screening? So usually we recommend after 50 years of age. So yeah, if you do, some of the corporate health screenings do tend to do prostate screening a bit early, and that may lead to some confusion. But generally above 50, we would recommend you to start yearly or every 2 yearly screening. Of course, if there's a family history of prostate cancer, let's say your father has prostate cancer, and even more so now we realize there are certain genes related to prostate cancer. For example, if there's a strong family history of breast cancer, pancreatic cancer, gastric cancers, then we will also suggest you to start screening a bit earlier at 45 years of age. So what are the steps of prostate cancer screening? So on the number one is actually we have discussion with you about what it means to do this prostate cancer screening, what are pros and cons. The reason why we have this discussion is because at one point in time in the US, they actually stopped prostate cancer screening. And what happened was, after 5 years, they realized that the number of metastatic cancers, or what we call cancers that have spread, or late stage cancers, had gone up. So nowadays, we would recommend you have discussion with your GP or your regular health provider to have discussion about whether you should do PSA screening at what age and things like that. So it really involves a PSA blood test. It's a very simple blood test. And when that is elevated, that means the risk of cancer has gone up, then we go on to do additional tests. For example, we may do a more sensitive blood test called a prostate health index. And oftentimes we would recommend what's called MRI of the prostate. So we image the prostate and look for areas where it's abnormal. So when we find these areas of abnormality, we can go on to do something called a targeted biopsy. So back in the day, that means when I was still trainee, where we didn't have MRIs and all that, the moment you had an elevated PSA, you would go on to do a biopsy. And this was what we'll consider a random biopsy. Nowadays, we try and do a targeted biopsy. So this is in the picture on the left. So imagine you do an MRI, you find an area that looks very suspicious. Okay, then now we have systems that allow us to actually target the area where it's abnormal, get tissue from it, and give us a better diagnosis of what's going on. In the past, before MRIs, we used to do that thing called a systematic biopsy, which essentially means we divide your prostate into zones, and from each zone we take a core. and hopefully we had hit the cancer. So obviously it's like tikam lah, you may or may not hit the cancer. Importantly, nowadays, we've also changed the way we do prostate biopsies. In the past, it used to be something called a transrectal biopsy, which means essentially we put the ultrasound in the backside and we puncture through the backside to the prostate. Obviously, there's an increased risk of infections with that kind of biopsies, and these infections, even though not very common, but when they happen can be very catastrophic. We have had patients die from prostate biopsies in the past before. So because of that, we've changed our approach. Now we do what's called a transperineal biopsy. So we biopsy through the skin, in the space between the rectum and the scrotum. That area we can clean nicely, we can sterilize it, reach a point where we almost hardly ever give antibiotics even before the biopsies. So because of that, the infection rate is much, much lower. We also oftentimes in private do our biopsies under a little bit of sedation, so it's very comfortable for the patients. They wake up, they're very happy. They're so happy they want to get the anesthetist phone number because they say, I slept better than I had in the last 5-10 years. Yeah, usually pain is also minimal. With my biopsies, I don't even give Panadol anymore to the patients because they're pretty okay. The main side effect is some blood in the urine for a couple of days and oftentimes a bit of blood in the semen. But all this resolves by itself. Okay, so when we do these biopsies, what happens? This is what we find, okay? So 50% of them are what we call grade group 1, okay? Then another bunch of them are what we call grade group 2 and 3, then 4 and 5. So essentially, we grade our cancers. So in the past, one of the reasons why the US stopped doing PSAs was because of what we call over-treatment. Anyone with a prostate cancer picked up went on to do some kind of other surgery or radiation, and those things led to even more problems in terms of urinary incontinence, in terms of bladder irritation, bleeding in the urine, all kinds of other issues, erectile dysfunction. But now we realize that with each kind of cancer grade, there is a different approach. So we know that 50% of the cancers that we pick are going to be grade group 1, and these are low-grade cancers. When we say low-grade, it means that in the next 15 years, the chance of it spreading is 2%. Not death, spreading. Just spreading is 2%. So most of the time, grade group 1 cancers, especially when they are a small focus, we don't do any treatment except something called active surveillance. If it's 2 and 3, what we call intermediate, this is when we start intervening because the risk of spread is higher, and even worse in 4 and 5 cancers because those are very aggressive cancers. So now, number one, we can decide who needs the biopsies. When we do biopsies, we are more definitive of the kind of cancer, and we have treatment plans based on the kind of cancer you have. So not everyone goes on to have surgery or radiation. So if you have what we call localized cancer, I think I'll leave Wong to talk to you about metastatic cancer. So I'll just focus on localized prostate cancer. So one of the hallmarks of treatment is what we call active surveillance. So this is when, especially as a grade group 1 cancer, one area, not all over the place. These patients, nowadays, we reassure them the chance of it spreading is low. We will monitor you. We will make sure we catch it before it spreads. Okay, so basically this involves repeated blood tests, sometimes repeated MRIs, and maybe even a repeat biopsy. Of course, if let's say it's intermediate or high-grade cancer, then we will talk about number one, actually staging the disease, which I didn't have in the slide. Basically, nowadays, we would do something called a PSMA PET scan, and this gives us an idea about whether the cancer has spread or not. If it's truly localized, then the options are either robotic prostatectomy or radiation therapy. So I'll talk a little bit about it in a while. And lastly, we have this new thing that's coming online. It's called focal therapy, where we only treat the area that is abnormal in the prostate. This is mainly to reduce side effects. But it is very much still considered experimental in Singapore because the results, I'll share with you the results in a bit. It's not fantastic. So active surveillance, you have discussion, and then we determine the risks, and then we start you on this program where we do blood tests. And normally about a year, we might do an MRI, and between a year and 18 months, we would suggest a repeat biopsy of the prostate. So with this, if you look at it on the left, the 10 and 15-year survival is excellent. It's as if you had a prostatectomy, essentially. Okay, so very, very good results. So low-grade cancers, we normally suggest active surveillance. Okay, then the next option, if you have something a little bit more aggressive, would be potentially a robotic prostatectomy. So this is a minimally invasive surgery. Usually what happens is a few small incisions, the robot is docked. As a surgeon, we control the robot. We disconnect the prostate and then we join everything back together, usually home after 1 or 2 days. Of course, you need to be on a catheter for a few days, and after that, we will take it out. So, with robotic prostatectomies, we have also had some advancements in the way that we do it. Number one is what we call nerve sparing technique. So if your cancer is in the early stage, which is why we keep emphasizing early, just like the breast cancer, we also emphasize early, then we can do something called nerve sparing. Basically, we spare the nerves of erection that lie literally next to the prostate. So by sparing the nerves, we get much better erectile recovery. Okay, and we also put you on sort of like erectile function recovery protocol also. The other thing we do nowadays is something called Retzia sparing approach. So this is a sort of a different approach to the robotic surgery. It's still robotic. We take out the prostate, but we leave as much of the supporting structures behind so that we can maximize or reduce the risk of urinary incontinence. So these are the two major issues with prostatectomies, erectile dysfunction and urinary incontinence. So by doing the Retzia's approach, the day that we take out the catheter, 20% of patients do not have any leak at all. And usually by 3 months, most of the leaks are really quite minimal. So these are some of the new approaches that we do in terms of prostate cancer, and especially when it's an early stage cancer and a small focus. Of course, we can do something else called radiation therapy. This is especially useful in patients who are a bit more elderly, especially with less than 10 years expected life expectancy. The latest version is something called proton therapy, which is even more targeted to the prostate and reduces damage to the rectum, because the rectum lies next to the colon lies next to the prostate. So we want to reduce that. If not, you get bloody stools and all that kind of issues. So along with radiation, it's about 3 to 5 weeks of radiation, but you do need some additional treatments, basically injections of hormones. This is really to block your male hormone, so sort of like to medically castrate you for a certain period. Minimum is about 2 to 3 months before radiation starts, and then another 6 months after. Okay. The good thing is that there is no surgery. You can carry on life as per normal even during the radiation. There are certain side effects related to narrowing of the urine tract, bladder irritation and bleeding, and rectal irritation. A lot of this is quite mild, though some of this can appear 5 to 10 years post radiation, and sometimes that can become a bit of an issue. That's why it depends a lot on life expectancy. If you have a shorter life expectancy, then radiation is a great option. If you have longer, beyond 10 years, then you may start facing some of these problems with radiation. So lastly, I want to quickly talk about focal therapy. And focal therapy really means that if, let's say, on an MRI, you can see the lesion and it's not too big and not too close to certain important structures, then we can potentially target only those structures. This will involve oftentimes a needle placed into the area where it's abnormal, and then we apply either cold or heat to kill the tumor. So it is usually a day procedure or overnight procedure. You may need a catheter for a few days, but generally very well tolerated. In terms of erectile function, most patients will have a dip in function, but it's not as big as if they went for radiation or surgery. The downside is that, similar to active surveillance, you do need consistent follow-up. So you will need to go on a PSA, almost like an active surveillance protocol. You will need repeat MRIs and you will need repeat biopsies. The recurrence rate is a bit higher, okay? So usually if patients are well selected for radiation or surgery for localized cancer, the recurrence rate is probably 10% or less. With this focal therapy, at least 20% of patients will have a recurrence of the tumor. So they may go on to repeated focal therapies, or they may go on to do definitive therapy, that means either surgery or radiation. So sometimes this may be a cure, but oftentimes this is going to be a temporizing measure until either you pass on because you're elderly, or because the cancer is getting bad enough that you need to have surgery or radiation. Okay, finally, I just move on to the take-home messages. So I think the first message I have is prostate cancer screening is important in males, especially after 50 years of age. I would say to you that nowadays, because we know how better to manage patients, we don't have to be worried about over-treatment and all this with prostate cancer, which was the biggest reason why active surveillance stopped, screening stopped in the US. The second thing is that, early detection saves lives. I show you in the slide that if you pick up the cancer because of screening early, that means localized cancer, your overall survival is 98, 99%, 5, 10, 15 years down the road. The moment it is metastatic, that means it has spread, your overall survival drops dramatically to 38% at 5 years and 18% at 10 years. Oftentimes all this is a lot of shared decision making. You need to talk to your doctor, decide how you want to approach it. For example, if I saw an 85-year-old man with some elevated PSA, maybe 10, 15, but let's say he's got end-stage lung disease, he's having oxygen given to him, then I'll be thinking, I don't think I even want to biopsy you, not even an MRI maybe even. And then we would just monitor as things go and then manage as required, because you're probably going to have a much shorter life expectancy. So all these are important discussions to have. If you have a family history of cancers, then you may want to push your PSA screening a bit earlier. And with any cancer, there is a need for follow-up. Whether you're on active surveillance, you do have to follow that protocol. You cannot say, I have low-risk cancer, I'm just not going to care, because sometimes we may miss a high-grade cancer on a biopsy, or over time, high-grade cancer may develop in the same prostate. Because oftentimes, prostate cancer is also multifocal. That means it's not only in one part of the prostate, but can appear in another part of the prostate, whether at the same time or even later on. So you do need surveillance. And if you're on focal therapy, even more important. And usually for radiation or surgery, the follow-up is pretty easy. We just do PSAs. We hardly ever do MRIs or anything additional. I have patients, I'm seeing them once a year or once every 2 years after they had radiation or surgery, because the results are very good. So I think that's about all I have to say. I think the take-home message really, if you pick up something early when it's still localized, then you're going to have a much better outcome than if you had metastatic disease. Thank you.
Thank you so much, Doctor.